Okay, we'll give 30 seconds, something like that, for all the people. So the first question comes, please chart it in the answer box. Initial FiO2, if you are ventilating or giving the positive pressure ventilation for a 28 weeks baby at birth, you have the options A as 21%, B as 21 to 30, C as 30 to 40, and D as 100%. Okay, I think all of them are already answering. Okay. I kept very simple, sir, this time because it's the first time they are attempting.
Oh, I think these are good learning experiences.
Yeah, okay. So, yeah, most of them have already. I think we can see a lot of people who are answering the B. I think that's good. So the message here is that for term babies, we have to give 21%. For preterm babies, current guideline says that it is between 21 to 30% if the baby is born before 35 weeks of gestation. That we need to remember. Okay. So then we will move on to second question. Yeah. Can you interpret the FE loop, that is the flow volume loop, which is there here, that you might be seeing in your this thing? I'll wait for 10 seconds, let the people answer. I think here the controversy is there, sir, in this thing. So here I think you should remember, see, I'll show in the animation the next line. Okay. So here, if you can see here, the background is that cement color one which is there. So in the red color, you are seeing that the leak is, it is not reaching the zero. So there is a leak in the flow. That's the reason why it is not reaching the zero. So that's why this much of volume is not coming to zero. This is a air leak. If you have air trapping, it will be like this. Okay. So it is not the air trapping, it is a air leak one. Okay. Even in intrathoracic obstruction also, the picture will be different. And in the extrathoracic obstruction, the scooping will become a little different and other things. And the other thing is the what do you call it? Hysteresis, which is there here, will be abnormal in both in the inspiration and expiration, especially if it is intrathoracic, especially if it is extrathoracic obstruction. In the intrathoracic obstruction, usually during inspiration it will be good, but during expiration it will have a little lowered hysteresis, which will be there on this thing. Okay, so that is a different thing. So third question is that you have a 72-year-old baby, which is almost Deepika's relevant case. You have a 72-day-old baby who is born with 27 weeks preterm, with a birth weight of 800 grams, is on CPAP with a PEEP of 4 and 21% on 72 day. Chest X-ray suggests to some atelectasis and hyperinflation. So we were using previously the NICHD, which is criteria for classification of the BPD. I think, Deepika, you told that BPD we need to assess only at 36 weeks. If you look at the NICHD, anything more than 28 weeks of 28 days postnatal life, if the baby is born before 32 weeks of gestation, we will take it as a BPD, but assessment will be done at 36 weeks. So there is a difference between the definition and assessment. Grading will be done at 36 weeks. Whereas here, so now you can grade this based on even NICHD 2000 and other things. Can we see the answers, sir? People are not answering much. The recent modification which has come or proposed classification is there in the 2018 to grade it. Previously, we were giving it as mild, moderate, and severe. Okay, I think this will be a learning lesson. Many of them are not answering. So this was the previous classification, that is in the NICHD 2000, when we were giving assessment at 36 weeks of gestation, post-menstrual age if the baby is born before 32 weeks of gestation. If the baby is born after 32 weeks of gestation, baby is having going home after 28 days or before 56 days, or discharging home while you are discharging home also, then you can do. So anything treatment with more than 21% oxygen for 28 days, that is a prerequisite, that is a definition. Then you have to classify it according to your mild, moderate, and severe. So if the baby breathing room air at 36 weeks of gestation or at 56 days of life, if the baby is born after 32 weeks, then you will call it as a mild BPD. That means that at 36 weeks of gestation or after 56 days, in other category, if the baby is not breathing on, if the baby is breathing on room air, you will call it as a mild BPD. Moderate is if the baby is having less than 30% oxygen requirement. Okay. Severe BPD is anything more than 30% or any form of respiratory support. Please remember it. Okay. So any form of respiratory support is also considered as severe BPD. So in this case, the baby was on CPAP and the baby was born at 29 and then 72 days have been completed. Though almost 38 weeks, the baby is post-menstrual. So this baby can be classified as severe BPD there. So then you have this 2018 classification which has come. In this, they have given us grades. Okay. To avoid this over classification of severe BPD, they have based on the CPAP and nasal cannula and hood oxygen and low flow cannulas if you are using, they have classified it. If the baby is having 21% FiO2 on CPAP, then you will take it as a grade 1. Suppose the baby is on nasal cannula and less than 3 liters, that is HFNC less than 3 liters, then 22 to 29% also will accept. If the baby is on hood oxygen with 22 to 29% or a nasal cannula with less than 1 liter and less than 70% oxygen, these are all the conditions where we will classify them as grade 1. Grade 3 is there when there is a more than 21% of oxygen on invasive positive pressure ventilation, or if the baby is on CPAP or NIPPV or a HFNC more than 3 liters and more than 30%, those are called as grade 3. Okay. Early death 3A, they have given it for the other morbidities and other things. So in this case, as you can see here, the baby was, I think question has been changed, PEEP of 4 and 21% FiO2. So it will come as severe BPD according to 2000 classification. Whereas in 2018 classification, CPAP and 21% FiO2, it is only grade 1. Okay, because the baby is only requiring 21% FiO2. Okay, please have this classification on your table on every day or while you are doing rounds for all small growing babies and start classifying it. You will remember it. Otherwise, it will be always be confusing. So the next question is on the sepsis. Which marker in the septic screen has highest sensitivity? Many of the times we'll be doing left and right septic screen. Okay. Many of them are correct. Though CRP is a easy marker, but it is not a very good marker. So I have told that it is highest sensitivity is there with the IT ratio, not the CRP or ANC or WBC. It is near to 88%. Okay. Next question is about what is the most reliable physical parameter in new Ballard scoring for gestational age assessment. I'm telling physical parameter. So you have genitalia, plantar creases, breastbud, and the skin. So physical parameters are very important, especially when the baby is sick. Neuromuscular parameters may not be easily doable. So physical parameters are much helpful when you are doing in a sick baby. And we should also remember, so the answer is here is genitalia, because the correlation coefficient is almost 0.64 or 0.69 here in many of the cases. Other have a little lesser correlation. That's the reason why it is not a reliable parameter. We should also remember that in the newborn alert scoring, it is in very premature babies or extreme premature babies better to do as early as possible in the life. So in the first 48 hours, if you do, especially if you are dealing with the babies with 24 to 27 weeks of gestation, it is better to do. And one study from PGH Chandigarh has shown that till 7 days also you can do expanded newborn alert scoring with reasonable good accuracy or this thing. So when you are doing and you have the LMP based thing, and then if you are comparing it with the newborn alert scoring, if anything more than 2 weeks discrepancy, ask your colleague to do once again. If it is still more than 2 weeks discrepancy, then you have to consider the gestational maturity according to newborn alert scoring rather than the LMP or this thing. Okay. So then next question is, which of the following is associated with hypernatremia? I have given you 4 conditions here. One is the pyloric stenosis with persistent vomiting. Then you have syndrome of inappropriate ADH secretion. And then you have diabetes insipidus and diabetes mellitus. Good. I think most of them has written. I thought some people will get confused with the mellitus insipidus. So diabetes insipidus is one condition where you can see the hypernatremia. You don't see a hyponatremia. SADH also, because of the inappropriate ADH secretion, there will be retention of water. In the pyloric stenosis, there will be loss of sodium. In the diabetes mellitus, there could be a pseudo hyponatremia, but it will be hypernatremia, which will be there at this thing. Okay, thanks. I think all of you have answered it. Good. So next question, one on the antenatal aspect too. At what gestation or from which gestation NST is more reliable? I think if you ask your obstetric colleagues, they will be doing left and right NSTs, but from which gestation it is more reliable? Okay, answers have come down. Okay, so I think always we should have some knowledge about obstetrics also from 32 weeks of gestation, because the sleep wake cycle is much better matured. That's the reason why you will be able to have more reliability. So I think all of you know that there should be one acceleration in 20 minutes at least by 20 beats per minute. So that is the non-stress test which we'll be using it as this thing. Okay. So then if you are doing for the lesser than 32 weeks of gestation, better to prolong the NST is the other thing that you can do. So at least for 40 minutes you have to do before taking a car, because in less than 32 weeks, the sleep wake cycle which is there is a little longer duration. Whereas by 32 weeks, more or less, it will be around 15 to 20 minutes. You will have from REM to NREM, sleep variation will be there. So that is how the NST will act out. Okay. Hope it is clear. So there is a little more theoretical question, but I just wanted to keep some of the theory also so that you will be a little stimulated to read all this thing. Which amino acid is having higher concentration in whey protein of human milk? Okay. So we'll go ahead. So first 3 are in lesser concentration. That's the reason why even in tyrosinemia, they say that one of the safest uh, milk is the mother's maternal milk if the baby doesn't have severe tyrosinemia or this thing. Okay, so the taurine is at higher concentration, and all the other 3 are actually having lesser concentration of this thing. Okay. Next is, I think this we have discussed already. Which of these is not a contraindication for Maxwell for neuroprotection? So, not a contraindication. So, as we all of us know that many of them will take 32 weeks or 30 weeks as a criteria to give the Maxwell. And we have to give at least a loading dose of 4 gram followed by 1 gram per hour, which is more important for us. Okay. So it needs at least a 5 hours period, 4 grams plus at least for 4 hours if you give. So or at least up to 6 hours, the maximum benefits are seen on this thing. So I'll go to answer and then I'll explain. Okay. So if the baby is more than 34 weeks, there is no role for Maxwell to give it as a neuroprotection agent on this thing. If the mother is at risk or fetus is at risk, you should not waste your time by giving the Maxwell there on this thing. Okay. And if you have stopped the Maxwell 12 hours prior, you should not restart infusion immediately because there is higher chance of toxicity on this thing. But in multiple pregnancy, you can give, there is no problem. So it's not a contraindication. So you can give in multiple pregnancies without any hesitation. Maxwell for this thing. Okay. Okay, this is one of the social question, but most of you might have read it. So according to new RBSK guidelines or whatever the RBSK guidelines so that now we have, what is the gestational weight and age and birth weight criteria that will qualify for screening of retinopathy of premature? That means that below which gestation and below which weight, we have to screen all these babies for ROP, because ROP is one of the major medical legal issue. Everyone should know about it. What is our national guideline? I think still I can see a lot of people not answering it properly, but please remember our national guidelines, that is from the RBSK, is 35 weeks and 2 kilos. Okay. So this is the minimum criteria. Between 35 to 37 weeks also, if you have exposed the baby to oxygen, still you have to do it. But in all the babies who are born less than 35 weeks and less than 2 kilos, you have to subject those babies for retinopathy of prematurity. Okay. Remember, I think it's a good exercise. I thought it's very simple. Okay.